Hello everyone, my name is Dr. Muhammad Farouk. I'm internal medicine resident at the University of Central Florida. I'm going to discuss about a very interesting case regarding the challenges in managing acute myocardial infarction associated with infective endocarditis. Introduction: acute myocardial infarction is a rare but recognized and a potentially serious complication of infective endocarditis. This case will highlight challenges surrounding the management of acute MI in the setting of septic coronary embolism, brain, spleen, and a kidney infarction due to septic emboli from a native mitral valve infective endocarditis. Case presentation: patient is 57-year-old female who presented with altered mental status, preceded by 1 week history of fatigue, generalized weakness, and episodes of numbular vomiting and diarrhea. Patient denied chest pain, shortness of breath, fever, C contacts, or history of intravenous use. Physical examination showed a thin, dry, lethargic female with general lesions over the palms and soles, ocularis nodes, and a splinter hemorrhage. Rest of the physical examination was normal, except heart rate of 135 beats per minute. Labs were significant. WBC count of 17,000, hemoglobin of 11.7, platelets of 89,000, and a point of care troponin of 0.28. EKG showed signs of tachycardia, but no other acute ischemic changes. Chest X-ray didn't show any acute findings. Blood cultures were collected, and patient was started on empiric intravenous antibiotics, vancomycin, and ceftriaxone. CT brain was without contrast was obtained. Was ordered. Troponins were trained, and next troponin came back 0.85. Heparin drip was stopped. Patient remained chest pain free. Echocardiogram TTE was ordered, and the cardiologist was consulted as well. CT brain came back and showed subacute infarction in the cerebral hemispheres. CT abdomen and pelvis was obtained as patient complained some abdominal pain at this point, and it showed infarction in the kidneys and the spleen. Heparin drip was stopped after we get the CT brain result. TTE showed EF of 55% with no any acute vegetations. Blood culture came back positive for MSSA. On day 3 of hospitalization, patient experienced chest pain with repeat EKG showing new diffuse ST segment elevation and PR depression is consistent with pericarditis. Troponin trended up. TTE was repeated and showed EF of 35 to 40% and possible vegetation on the mitral valve. TEE, transesophageal echocardiogram, was performed on day 4, which showed EF of 30 to 35% with a medium-sized vegetation on the atrial aspect of the mitral valve, and also moderate to severe mitral valve regurgitation. Cardiothoracic surgeon was consulted. Post-TEE patient developed shortness of breath and decompensated rapidly into cardiogenic shock. Patient was placed on vasopressor support. Troponin trended up 49.5. At this point, the cardiologist and the cardiothoracic surgeon came together and decided to proceed emergent cardiac catheterization, which did not reveal any signs of coronary artery disease, but 100% occlusion of LAD, suspicious for a septic embolus. As you can see, the blue arrow figure 2A. Patient was transferred into cardiac ICU for further stabilization, and she successfully underwent mitral valve replacement with coronary artery bypass grafting next day. Cross specimen showed vegetation of the mitral valve, as you can see the figure 2C. Patient was discharged 11 days after the surgery with 6 weeks of IV antibiotics. Discussion: acute myocardial infarction secondary to septic coronary emboli is rare and usually fatal if left untreated, and it can cause a long-lasting complications even in patients who survive. It usually occurs within the first 2 weeks. Its incidence is estimated to be 2.9% in a series of cases of 586 patients with infective endocarditis. Risk factors associated with increased coronary embolism include presence of mobile vegetation, size of the vegetation more than 10 mm, Staphylococcus aureus, or non-viridinous strep infections or previous embolism. Our patient had the three risk factors. There have been different approaches used for the treatment of septic coronary emboli. This includes balloon embolectomy, coronary stent placement, anticoagulation, fibrinolysis, surgical embolectomy, or CABG. Balloon embolectomy can risk dislodgement of the emboli into distal small arteries, and it cannot eliminate the risk of the emboli. Coronary stent placement is associated with stent infection, especially in the setting of active infection, and it can cause a mycotic aneurysm that can cause coronary artery rupture. Anticoagulation and fibrinolysis are ineffective in the setting of septic emboli, as this is made up of inflammatory cells and a bacterial clonies. Surgical embolectomy can risk seeding of the bacteria into the myocardium, and it can cause left ventricular wall infection, which can lead to a ventricular rupture. In contrast, the emergent CABG presents a viable option for the perfusion of myocardium while avoiding the complications seen in other interventions. In this case, the combined benefits of mitral valve replacement and bypass grafting outweighed the risk of surgical intervention. Follow-up and outcome. Repeat TTE on post-operative day 1 showed EF of 10%. EF improved 20% on post-op day 5. Unfortunately, 3 weeks after the surgery, the patient died of cardiac arrest, secondary to hyperkalemia, secondary to seizure. Conclusion, there are no clear guidelines for the management of acute MI due to infective endocarditis. Diagnostic and angiography of coronary artery should be obtained in patients with active infective endocarditis presenting with elevated troponin or acute left ventricular dysfunction seen on echocardiography. Coronary artery occlusion should prompt immediate cardiothoracic surgery evaluation for consideration of emergency CABG with simultaneous valve replacement. And this brings me to the end of our case discussion. Thank you so much for giving me the opportunity to present this case. I will further elaborate during the main discussion what's interesting in our case. Bye for now.